Hello, everyone. My name is Matthew Webb, and I'm a student physical therapist with a CSCS and a BS in nutrition science. Today, I'm going to be talking about calcitriol, or 125 cholecalciferol, or vitamin D. Now, I need to preface this video by saying I read a journal article once, which was essentially a hit piece against a different journal article that was referring to vitamin D as calcitriol. Calcitriol and 125 cholecalciferol are different terms to describe the active form of vitamin D. The hit piece article was saying it was somehow harmful to refer to vitamin D by the name of its active forms instead of its dietary form. I don't agree with that, so I'm just going to keep doing it. If you disagree with me, then please don't write a hit piece article for a journal about me. Just write a comment below and I'll pin it so that others can educate themselves and decide if they want to follow your advice. This here is going to be the ninth in a series of educational videos intended for healthcare professionals to help us in direct access healthcare fields become more adept at identifying nutritional deficiencies so that we can get patients presenting with one of these diseases the help that they need. So, without any further ado, allow me to present to you calcitriol, or vitamin D. Firstly, we're going to go into the very basics behind deficiency of calcitriol. Then we'll break down the science behind why patients are presenting the way that they do. Then I'll give you some takeaways to help you identify this disease. When a patient has calcitriol deficiency, they develop decreased bone density, skin inflammation, respiratory infections, and hypertension. And we'll go further into the science behind these presentations and the risk factors later in the presentation, but I just want to provide you an idea of what we're going to be getting into in this lecture right here. 125 cholecalciferol interacts with VDR, which is the vitamin D receptor in enterocytes, increasing transcription of specific mRNA. The mRNA will be utilized to upregulate TRPV6, which is a passive calcium selective ion channel, calbindin D, which is a calcium binding protein, and PMCA1B, which is a pump that moves calcium out of the cell against its concentration gradient. Inside the enterocyte is a low concentration of calcium relative to external concentrations, thus driving the passive entry of calcium through the TRPV6 channel into the cell. Calcium binds to calbindin D, which buffers the ion so it doesn't disrupt cellular processes, and it shuttles it to the other side of the cell. There, PMCA1B actively pumps calcium into extracellular fluid, in this case, blood. Vitamin D, again, interacts with the VDR receptor. The structure will now bind to RXR. The If you remember from the retinoid X receptor from the vitamin A lecture, this guy actually makes a comeback here. And those two, VDR and RXR, form a heterodimer, which is two different polypeptide chains forming a protein complex. This structure then binds to DNA. Once bound to DNA, it will cause either gene expression or repression. Differentiation of a variety of pro-inflammatory T helper cells and B cells are repressed, while differentiation of cells that suppress immune response, such as Treg cells, are expressed. These effects are important in preventing an overly inflammatory autoimmune environment and maintaining immune system homeostasis. Vitamin D decreases the inflammatory mechanisms of the immune system. Chronic integumentary inflammatory diseases such as atopic dermatitis or eczema, or chronic integumentary autoimmune diseases such as psoriasis are exacerbated by vitamin D deficiency. These are complex diseases with many contributing factors, and vitamin D deficiency may not be the cause. So, consider whether the patient has risk factors, which will be on the next slide, before assuming they have a vitamin D deficiency. All right, here are some risk factors you can look out for. Alcoholism impairs vitamin D absorption due to the intestinal damage. It can also cause liver damage, and the liver is where one of the conversions of vitamin D on its journey to becoming its active form takes place. This can also lead to vitamin D deficiency. Hepatitis B and C and other liver diseases impact vitamin D levels because the liver is where the first hydroxylation of vitamin D takes place. So, liver health is important to maintain this function. Kidney disease impacts vitamin D because it's where the second hydroxylation of vitamin D takes place. So, kidney health is important to maintain this function. Cystic fibrosis is another potential cause of vitamin D deficiency due to thick mucus blocking the lipases produced by the pancreas. This decreases fatty acid breakdown as well as lipid soluble vitamin absorption. Celiac disease is another risk factor because it causes intestinal damage and decreases absorption. As far as drugs go, orlistat, which is prescribed for weight loss, decreases fat absorption, which decreases lipid soluble vitamin absorption. Cholestyramine and other bile sequestrants lower cholesterol by decreasing bile reuptake in the intestines. This process decreases lipid soluble vitamins. Some subjective questions to ask would be about past medical history, and you should make note of liver diseases, kidney diseases, cystic fibrosis, and celiac disease. Ask them what medications they're taking. Make note of orlistat and cholestyramine and other bile sequestrants. Ask about any alcohol consumption, and of course, find out what that looks like. Diseases that individuals can be at greater risk for with vitamin D deficiency are osteoporosis, psoriasis, atopic dermatitis, and multiple sclerosis. As far as clinical exam goes, in the integumentary system, findings would be exacerbations of psoriasis and eczema. Immune system findings are potentially increased or recurrent respiratory infections due to an increased inflammatory autoimmune state. The main takeaways as far as the what, how, and why behind the presentation is that calcitriol deficiency can cause decreased bone density due to decreased calcium absorption because vitamin D is responsible for upregulating mRNA for TRPV6, a passive calcium selective ion channel. Galvitamin D, a calcium binding protein, and PMCA1B, which is a pump that moves calcium out of the cell against its concentration gradient and into the bloodstream. Calcitriol deficiency can also cause autoimmune issues because the epigenetic effects of vitamin D repress differentiation of pro inflammatory T helper cells and B cells, while differentiation of Treg cells, a cell that suppresses immune response, is expressed. The integumentary exacerbations are also due to the over-inflammatory autoimmune environment associated with vitamin D deficiency, which can cause eczema and psoriasis exacerbations. And here are my resources. Thank you for watching. Note that I am making these presentations during a pretty busy semester, so I'm liable to have made some mistakes. If so, let me know in the comments, and if your correction checks out, then I'll either add it to the video description or I'll pin your comment. If you learned something from this video and you want to learn more, continue on to the Cholecalciferol or vitamin E video.